Namaskar दोस्तों and warm welcome to yet another episode of Dr. KK's Obesity MEDtalks. आज की हमारी 1023वीं टॉक शो है. It's our 1023rd talk show and I am your friendly and familiar endocrinologist Dr. Sanjay Kalra. आज की headlines देखते हैं क्या है. Let's see the headlines for today. Now, the World Health Organization says that multiple epidemics, multiple pandemics are occurring in the world. COVID-19 to chala gaya, but that has left other pandemics of mental illness, of metabolic illness. Research also shows that the prevalence of diabetes is increasing year by year, and so is the prevalence of mental ill health. Other research from USA as well as India shows that mental ill health is occurring in younger and younger children and adolescents now. A study from Nepal shows that you can use yoga and you can use relaxation and meditation techniques to prevent mental illness and also to promote mental health in people living with disease. Now, with all these headlines, suddenly it becomes a bit scary. थोड़ा सा डर लगता है ये इतनी सारी बीमारियां कैसे हैंडल करें. So let's learn about them because जब हम सीखेंगे, जब हम ज्ञान लेंगे, when we learn, when we get knowledge, that is the first step towards managing illness. So let's see what our topic is for today. आज का topic देखते हैं. The intersection of obesity and mental health. ये दोनों चीजें इकट्ठी होती हैं क्या? We never knew. So let's find out. So for this, we need an expert in mental health, and we also need someone who has studied a lot, who has studied extensively on obesity. So a warm welcome to Dr. Babita Sharma. Warm welcome, madam.
Thank you, sir. Thank you for having me in the program.
Thank you so much, madam. To introduce you to everyone, Dr. Babita is a psychiatrist qualified from the prestigious PGI at Chandigarh, and she has also worked at the prestigious AIIMS New Delhi. And now she works, her practice spans both Nepal and India, and her online presence is increasing day by day. She is able to take care of people across the continent. So Dr. Babita, warm welcome.
Thank you. Thank you, sir.
आपको गुड इवनिंग आ रही है स्वप्ना जैन जी से. मैडम इज अ हेल्थ एडवोकेट फ्रॉम वेलोर, और एक और गुड इवनिंग आ रहा है फ्रॉम बिमला कपूर मैडम. तो ये सब पूछ रहे हैं कि आपने साइकाइट्री क्यों चुना एज अ करियर.
Because of passion, I would say, and I'm more interested into the psychology of human beings, so that led me to become a psychiatrist.
And we'd really love to learn from you because all the people who log in to KK MEDtalks, we are all people. So I know Swapna Jain ji, for example, we are all actually interested in psychology of health, psychology of disease, both. So madam, you have chosen a very difficult topic, intersection of mental health with metabolic health, mental health with obesity. The floor is yours. How can we understand? I thought ये बिल्कुल अलग-अलग चीजें हैं. How are they connected to each other?
I would like to say that obesity is not only a metabolic or endocrine disorder. It has been a close connection with that of brain disorder. So that is the main reason. So that is what I'm going to present today. So now I'd like to have the slides for the presentation.
Thank you, madam. And we look forward to learning from you.
Shall I begin? Shall I begin, sir?
Yes, please carry on. The slides are visible.
Good evening, everyone. And so I'd like to begin my presentation with this outline. So first, I'll introduce why the mental health and obesity intersection is there, and followed by different etiopathogenesis of obesity with many of psychological correlates, and how the association between obesity and psychiatric disorders occurs, and the psychosocial consequence because of obesity, followed by the management and role of a psychiatrist in the same. So I would like to begin the presentation by one thing, that our human behavior of eating involves a complex process, and that is because of interaction of the mind, body, and the brain. So psychiatric symptoms are also present here As we know that obesity is not only an epidemic as declared by WHO in 1998, it was over the years considered to be a evolving pandemic, as the obesity is being associated with a growing surge of the neuropsychiatric problems with many of neuroendocrine etiology. So, as the society is changing, the prevalence of obesity is increasing with more introduction of the modern lifestyle and more overabundance of the energy dense food. And because of sedentary lifestyle and decreased opportunity for the physical activity, there is a evolving of the both obesity and the psychiatric condition. So coming on to the etiology of obesity, it involves multiple etiology. So first, I would like to talk about the genetics of obesity. Most of the studies had suggested that in adoption, twin, and family studies, there is a strong heritable component, and it ranges from 30 to 70% of the variability in the body weight or the fat mass that is genetically determined. So how is that? With the two important ways, that is appetite and food regulation, and next is the energy expenditure. So in an attempt to understand the obesity in all of its dimensions, second, the etiopathogenesis is the behavioral genetics. So what it is a contribution of the genetic variability to the related behavior, that is eating and physical activity. So behavioral factors such as more preference towards the fat foods, choice for repeated eating, degree of calorie compensation in response to the food restriction has led to a more engagement towards the genetic component. So apart from the genetics, the things that are not explained by the genetics is the next environmental factor, and dramatic environmental changes over the past 30 years has acted together to create an obesity promoting toxic environment, thereby resulting in even the evolution of the thrifty phenotype, which is the energy efficient and fat loving individual now with the ready availability of the fat high calorie foods. The significance has led to the obesity. The next third factor is the social and cultural factors. The evidence that obesity affect is seen more in female than that of men, and also it has been reported in many of the studies that those population who are in the lower educational attainment and who are from the lower socioeconomic status, they are considered to have higher rate of obesity. The most important today's topic is, as I said earlier, that obesity is also a brain disorder because it follows the hypothesis of the addiction model and the neuropsychological factors that contribute to as mimicking that of the addiction like behavior. So obesity is characterized by the compulsive eating behavior and inability to get refrain from that despite knowing the fact that it is not desired to do so. So it has a parallel connection like that of the substance dependence that we use in the drug addiction. So there are certain diagnostic criteria that we use in order to diagnose the substance dependence. So similarly, there is a strong suggestion that obesity is also considered to be a kind of food addiction. So let's see the comparison, how the corresponding things occur together. In case of substance dependence, there are basically different international classification of disease says that six diagnostic criteria it presents. Like when there is a drug dependence, one should have an increased craving for that drug, and followed by the tolerance. And in absence of the drug, there is a withdrawal symptoms. And despite knowing the fact that this is not useful, like that is harmful, still the person tries to pursue that, and with discontrol the behavior continues on. So corresponding behavior for obesity, there is a increased amount of food to maintain the satiety, and even if the patient does not feel hungry, still he or she continues to increase the food. And when the food is not eaten, then it leads to a emotional dysregulation in form of distress and dysphoria, and there is a persistent desire for food and unsuccessful attempts to cut down the eating pattern of behavior, and larger amount of food are eaten that are not much required to do so. So apart from that, as I said, that like avoidance or neglecting the pleasurable activity, a great deal of time is spent by a person who is dependent to the drug. So in case of obesity also, those who are obese, they spend great deal of time by eating, and the activities are also given up from the fear of rejection because of obesity. And the overeating is maintained despite knowing the fact that it has adverse implications in terms of physical and psychological consequences because of excess consumption of food. So for that, let's understand the eating for pleasure. There are two different pathways the eating behavior is linked to. The eating for pleasure is basically when even the needed calorie is there, but still the eating for pleasure is there because of this hedonic pathway. The eating behavior is actually regulated by the two different pathways. One is the homeostatic pathway, that is a normal pathway, and next is the reward pathway, which is also known as non-homeostatic or hedonic pathway. The energy sensor in this pathway are the gut hormones, that is GLP-1, cholecystokinin. So whenever the food particles enter the stomach, there is a release of hormone and leptin from the adipocyte. It causes to give the signals to the brain along with the vagus nerve. It gives signal to the higher center, and it causes anorexogenic signals to the higher brain center. The person feel to have satisfied the hunger and stop. But what is important in this pathway is that this conveys an anorexogenic and orexogenic signals in the arcuate nucleus of the hypothalamus that consists of the two type of neurons. Here we can see POMC. It gives rise to completion of the completion of the food. But however, because of the reward pathway, person feels to eat more, and this leads to the addiction like eating behavior. So with the sensory cues, like when there is a presence with the vision, when there is a presence of hyper palatable food, it causes the reward center getting activated because there is a surge of dopamine, because of increased signaling that occurs. And with even the distraction, person is not able to escape away from the food. And so continue pattern of eating, that is continued unhealthy eating despite knowing the adverse effect, it is linked to the addiction like eating behavior. So let's understand disrupted brain functions that is implicated in the behavioral phenotype of addiction and obesity. So we can see that the person has stress. Everyone has stress in day-to-day life, but whenever there is a chronic level of mental stress, it causes some changes in the brain centers, basically the prefrontal cortex, the occipital, parietal, temporal cortices, especially the hypothalamus, which has a homeostatic regulation, the amygdala, hippocampus, and the reward center, it get affected, and this leads to the enhanced desire to have the hyperpalatable food. So there is a dysregulation in these different brain regions, leading to more intake of food. So coming on to various neuroimaging studies that have been shown upon eating, that what happens, there is a release of a dopamine and in the mesolimbic circuit, and that is correlated to give the increased sense of reward, like person has a subjective feeling of the pleasure. So what happens in the reward deficiency syndrome, in this model, there is a deficit of dopamine due to receptors, and this leads to hypodopaminergic trait, causing the brain to seek more stimuli, that is food, drugs, in order to feel satisfied with the reward and gain the pleasure. So in case of hypodopaminergic trait, it is most apparent in the patients of eating disorder, very commonly seen in the bulimia nervosa, that may occur to a varying degree in other obese individuals. So currently it has this hypothesis has been criticized by many for the lack of not good evidence, and for that it will further increase the stigma associated with the obesity. Coming on to the various psychological factors that are associated with obesity. First, let's understand the psychological status. So as per the Sigmund Freud, there is a various psychosexual stages. So out of that, the first is the anal stage. That is the anal phase, which is between after birth to around 18 months of a child. So here, overeating is the product of a deep sense of dependency that arises in the oral stage of development, when the basic need of the infant are not fulfilled, when the baby is hungry, not able to get adequate breast milk, then there is a central tenet with this model that the person become a dependent person in future, who will be preoccupied with food and eating as a means of obtaining security and form of sustenance. However, the relationship between obesity and dependency score was later shown to have no such association. The next is the role of personality as a psychological factor. It has been shown in multiple studies that those individuals who have a certain personality trait, like those who have a borderline personality trait, they have difficulty in emotional regulation, and they have a fear of abandonment. They are a person who come with a low self-esteem, low self-control, and because of that, it is also contributed as a personality trait to that leads to obesity, and also as a comorbid condition they are seen to have a binge eating or other eating disorders together. So others have also highlighted an association between the higher body weight. The personality assessment plays an important role while assessing the individual who comes with obesity and many other comorbid conditions, that he or she will benefit from the multiple approach of treatment. Like it involves like psychiatric assessment, pharmacological, psychotherapy, so on, that has an important role to play. And also we should consider the early insult, that is in form of childhood sexual abuse or in terms of emotional or physical abuse, in those children who come from a dysfunctional family, who have a difficult childhood, and especially the girls who were sexually abused are more likely to be obese than compared to those who are not. So it is also associated with the abnormal eating behavior. There is a study which was done among sexually abused and who never reported to have sexual abuse in their past history. So till 20 there was not much difference in the rate, but however 42% of the abused and 28% of the comparison subject were obese, that were after the age, that were above age of 20 years. So consequence of sexual abuse also has a close relation with having future risk of depression, body shaming issues, body dysmorphic disorders, low self-esteem, having a poor social connection, and who have a history of binge eating patterns. So that also amplify the risk of psychosocial risk, and that leads to the development as well as maintenance of obesity. I'm sorry for this slide because I'm not able to provide the animated view, but still I'll do my best. So this is one study that shows a relation between psychology of obesity. This is a review study which has compared the association, which has included many of the cross-sectional studies, and have tried to show the psychological factors as a connection with that of heavier body weight. It says that there is evidence of relationship more to the mental health, and especially convincing evidence is there in case of children. So they have a history of mental illness in terms of anxiety and depression, and also in case of adult, very strong evidence with that of depression. Also, apart from that, the cognitive factors that are also involved includes like those who have a history of obesity, they have high other cognitive problems in terms of increased impulsivity, habit of like increased reward seeking behavior, and impairment in the executive function, and the temporal perspective also plays an important role. However, if we see here, the psychosocial majority of the meta-analysis were not able to provide the strong evidence for the same. The study has mentioned that it could be because of relatively low methodological quality, and therefore it carries a high risk for the bias. But there is seen that the evidence for no relationship in that the psychological trait of the individual who are more extroversion, like who are more open to communication, who are more agreeable to the situation. So there the strong correlation is not shown. So next is I would like to discuss on topic related to the psychiatric disorders and connection with obesity. So the question arises, are the psychiatric disorder more common among the obese individual than the non-obese? The evidence, available evidence, there is a mixed results. So let's understand each of them. So first, the obesity and psychiatric disorder, as I already mentioned, the association with that of depression in adult and even in the children. So it says that obesity and depression has a bidirectional relationship, also a reciprocal risk factor for the same. And many of the epidemiological studies have shown that among the mood disorders, predominantly the major depressive disorder and the bipolar disorder are more likely to develop obesity than the control population. And patients with obesity are at also increased risk for developing the mood disorders. And notably important link has been related to the major depression. There was once one in a study, there was a 1 year prevalence of the major depression of around 37% higher among the obese female than that the average peers. So in another study, those who were morbidly obese, there was an increased likelihood of depression in the recent past. And it has also been suggested that more extremely obese individual experience body shaming, social stigma, discrimination, and that also amplify the risk of depression in the future. So let's understand each of those subset of factors that are the moderator in that contribute to both mental illness as well as obesity. So one is discrimination, as I said, social stigma, low self-esteem. They come with a low self-esteem. There is a history of childhood sexual abuse, and they have a body image issues. So the gender should is play a very important role, because in most of the research mentioned that women are at more risk. And socioeconomic status, those who come from a lower socioeconomic class, and also genetics as well as environmental interaction play an important role, and adverse childhood experience. So these important moderators are contributable to cause of both obesity as well as mental health issues. Next is the eating disorder. So there are basically available evidence that the eating disorder in terms of binge eating pattern, bulimia nervosa, night eating disorder are associated with obesity. So about the binge eating disorder, it was formally defined in the Diagnostic and Statistical Manual for approximately, the study says that 30% of the subjects who meet the diagnostic criteria for the binge eating disorder, whereas in the general adult population, it is only around 2.5%. So, what is binge eating disorder? It is a pattern of recurrent episode of binge eating. So, that is in a certain period of time, mostly within 1 to 2 hours of time, and they have an increased amount of food. They take large volume of food despite knowing the fact that they are not able to control the same, and the binge eating episode continues, and they just keep on eating rapidly. And also they are not able to control that, and even they eat large amount of food even when not feeling they are physically hungry. So that results as a consequence increased distress, mental distress, and they feel disgusted after the same, and they end up into posing pattern of behavior, like they vomit out, and they do exercise, they do fasting so as to maintain back the body weight. And this does not occur exclusively during the course of anorexia nervosa. So when compared to the obese woman without binge eating behavior, those with binge eating disorder are characterized by the early onset of obesity, and they have more fluctuations in the body weight, and they come up with the low self-esteem issues, and they come up with many of the psychiatric comorbidities. The next is the night eating disorder. This was not formally defined, but it is mentioned in the DSM-5 as the eating pattern of behavior, and it is more linked with the circadian pattern disturbance in the eating form. So they have the habit of eating in the evening. They eat a lot at the evening time, and they are awakened at the night time, and they crave for the food and they eat. So this pattern of prevalence increases with the increasing weight, and in the general population to 8.9 to 15% in obesity clinic they come up with, and from 10 to 42% among the obese persons undergoing the assessment for the bariatric surgery. So now understand, is obesity more common in patients with psychiatric disorders? Yes, there is a multifactorial causation for both obesity as well as the psychiatric disorders. The estimated prevalence for excess weight is particularly common in patients with mood disorder and psychotic disorder. The multiple causations, the biological cause, psychological cause, the medication induced weight gain, and the pattern of behavior the patient have, like those who are physically less active, who have a habit of eating a lot, so they this all leads to both eating disorder as well as mental disorders. So next one is the bipolar disorder. The female bipolar patients have significant higher rate of overweight, with come up with the abdominal obesity than that for the control group, as mentioned in the various studies. The obese people also had poorer treatment outcome than the non-obese individuals. However, there was no differences with respect to recurrence in case of mixed mania, mixed episodes, and so on. So next is obesity in relation to schizophrenia. As medications that we give are the antipsychotics. In earlier times, there were a typical antipsychotics only, but with recent advances, we have the second generation antipsychotic medications, but that carries a lot metabolic side effects. So it is more responsible for the metabolic syndrome, and so several of the psychiatric medication are now known to be associated with the weight gain. So basically it includes the second generation atypical antipsychotics, most of the antidepressants, that belong to the selective serotonin reuptake inhibitors, and other group of antidepressants like cyclic antidepressants and metazepine carries a more weight gaining potential. And among the mood stabilizer, the lithium and valproate are uh, responsible. So we can see here this in this picture there is a mean change in the weight with the antipsychotic, and more to do with the second generation like risperidone, quetiapine, olanzapine, clozapine. It comes with more weight gaining potential. So patients receiving the mood stabilizer like lithium or valproate, the studies has mentioned that there is a possibility to gain a weight at a mean of 6.3 kg to 6.4 kg respectively, whereas the patient receiving topiramate lost a mean of 1.2 kg. So that is, topiramate can be used in such individuals who have the history of obesity and the mood disorder, that is the bipolar disorder. So among the antidepressant that I already reported, amitriptyline and mirtazapine are known to cause weight. However, fluoxetine is the SSRI which is supposed to cause a less weight gaining potential. So let's come to the psychosocial consequences because of obesity. The most important is the body image dissatisfaction and low self-esteem. So these individuals have the difficulty with respect to their physical appearance, and especially this is true for the adolescent woman and young woman. So nearly half of the women in general population also give a generally negative evaluation for the appearance. So in majority of the studies that has reported that around in a study 68% obese who sought weight reduction, and 33% of non-obese reported modest to extreme dissatisfaction with their overall appearance even after the surgery. So this was the most dissatisfying feature, that also is one important risk that can cause the depression and other mood issues. So several studies have found a relationship between the increased body image dissatisfaction, increased risk of depression, and decreased low self-esteem. The next is the stigma. Overweight employees are assumed to lack the self-discipline. They are stigmatized to be lazy. They are stigmatized to be less competent and disagreeable, emotionally unstable. So obese employees are also believed to think slower and have poor attendance record. So experimental research in psychology consistently have demonstrated that they are being stigmatized because of their weight, as is perceived to be a causative factor, which the people stigmatize, telling that it is in their personal control, but in fact it is not in their personal control. Next is the quality of life is affected, impaired, and because obese people in general have been found to have a lower quality of life, and there is a strong relationship between the BMI and poor quality of life. So obese women tend to report poorer health related quality of life than who are not obese. The individual in the community who do not seek treatment had less impairment in the perceived health, while individuals seeking the bariatric surgery had the most impairment because of the body image issue. So let's now understand why the individual as well as public health consequences is related to the weight stigma. So because of weight stigma, individual feel mentally stressed, and they develop unhealthy coping, that is eating to satisfy and to get the temporary relief. So unhealthy eating pattern occurs, and this causes to lower the physical activity. They emerge with one of the other psychological disorders, the stress induced psychopathology, and then also a public health consequences occurs because it leads to a degraded social and environmental contributor to the obesity as an environmental cause. And also this also leads them to just seek less health requirement, so increasing the morbidity and mortality. So let's come to the various management approaches that we do to manage the weight reduction. uh, uh, yes, it comprises of various pharmacological, non-pharmacological approaches with combination of both, and also the bariatric surgery. However, most of the talk I think that has been going on in the periodic classes. So today I'll basically focus on the behavioral therapy. So let's understand behavioral therapy. Like it does not refers to the specific diet or the exercise plan that is adopted, but rather it is the principle and the technique that is used to change the person's pattern of thinking, behavior, habit, like learning a new techniques and unlearning those which are not helpful in the past life. So what are the behavioral therapy? It comprises of self monitoring, stimulus control, cognitive restructuring, nutritional education, physical activity, and various problem solving, coping skills, and relapse prevention therapy. So it falls on the principle of classical conditioning that we all know, that popular dog experiment. Whenever there is an unconditioned stimulus, we get unconditioned response. Like salivation, dog has a salivation. So when there is a neutral stimulus, there is a no response. But when we mix the unconditioned as well as conditioned stimulus at a time, then we get the unconditioned response, and thereby it holds that the stimuli that we get, which is repeatedly presented before or simultaneously, that is responsible to cause a behavior that is associated with continuation of that behavior. So, what is self monitoring? It is basically recording one's behavior. The most important component is in terms of the behavioral therapy. So, like taking a detailed account of what kind of food is taken, how much calorie is taken, and how many times the physical activity is done, what are the schedule for physical activity, and what is the weight record at subsequent interval of time. So, we request the patient as well as the family members who accompany them, who take part in their treatment process, to just frequently self monitor, and in order to go with the treatment plan for the long term weight loss management. And stimulus control is the second step, where the various cues that the patient gets the stimuli, so thereby there is a pattern of eating. So what happens is, with the control stimulus technique, the patient learns to manage the cues and get a lot of distraction technique that is associated to just have a mindful eating, so as to continue the pattern of weight loss. So next is the cognitive restructuring. It is a part of cognitive exercising. Like we have to assess uh, irrational thoughts that the patient holds related to the weight control efforts, and we teach them to just practice the various alternative technique. So patient identify their own negative thoughts and try to self monitor and play the mindful rational responses, and this helps to do so. So what we do and don't do often results from we think and feel. So for example, when you feel sad, when you feel anxious, when you feel stressed, then what happens? This leads to a eating pattern. But unless we act to address these emotions, so acting on these emotions, that helps to avoid the short term coping mechanism, that is the unhealthy coping mechanism, and relearning the long term problem solving skills. Basically, such type of behavioral management is provided weekly for an initial period of 16 to 26 weeks. So couple of the sessions has to go on, and it is practiced for a period interval of 60 to 90 minutes in each session. And this can be done by dietitian, behavioral psychologist, and other healthcare professionals. Apart from that, relapse prevention strategies and correcting the negative thinking pattern, and just making them understand the high risk situation and cues in describe how to control that problem behavior. So these are later on, we do as in part of cognitive and behavioral therapy as well. So for long term weight management, there is a summary of results from the 7 different studies about the behavioral treatment that was extended beyond 6 months. At the end of the treatment, the group receiving the behavioral treatment, it was shown to have reduced the net weight loss of around 5.5 to around 16 kgs, that of initial weight. So talking about the pharmacotherapy, switching when the patients who are taking the psychotropic, especially the antipsychotic, they are preferably given on basis of individual to individual preference, because those who come with already obesity and the psychosis, then the preference should go with those antipsychotic drugs that possess low weight gaining potential, like aripiprazole, ziprasidone could be a choice. And for antidepressant, if we have to start, we should preferably use the fluoxetine group, bupropion, because that has a weight reduction potential. And for the mood stabilizer, we basically use the lamotrigine, topiramate. However, during the switching, careful monitoring must be required so as to prevent the destabilization and relapse of the symptoms. So shift in risk perception of antipsychotic. In the past, the main worries was related to the extrapyramidal side effects like tardive dyskinesia, and but at present, with emergence of second generation antipsychotic, the more medical comorbidities of concern are diabetes, dyslipidemia, coronary heart disease, and mainly the weight gain. So we have to be very cautious while choosing the antipsychotic medication. And also, this is already discussed previously, that more of the tricyclic antidepressant group of drugs, MAO inhibitors, they have increased potential to gain weight compared to that of SSRI. Among the mood stabilizer, lithium and divalproex contribute to more weight gain compared to that of carbamazepine, oxcarbamazepine, lamotrigine, topiramate, and so on. So how the mechanism of weight gain occurs with psychotropics? So it is basically through appetite regulation, because the psychotropics has a tendency to cause activation of the neuropeptide Y in the arcuate nucleus of hypothalamus. Thereby, it causes increased release of ghrelin, and that leads to the pathway that I already discussed in the homeostatic pathway. It leads to the activation of the orexogenic neurons and causing more intake of food. Second is energy storage and expenditure, or typical antipsychotics are supposed to give excessive body fat deposition and adipogenesis. So now this is a very hot topic of discussion. Like in subsequent lectures, like there has been many discussion related to the glucagon like peptide 1 receptor agonist, like semaglutide, a recent drug, and the liraglutide. These are the GLP-1 receptor agonist, and they are used as a second line treatment for the type 2 diabetes, and has also been approved by FDA for the weight reduction strategies. But however, many of the clinical trials report that this is associated with the many of the neuropsychiatric conditions. And this is one study where the psychiatric adverse effect has been reported. And it is said that among like most of the reports that was done, it mentioned that there is a more risk of suicidal thought and other psychiatric adverse effect in terms of increased risk of self-harm, and very commonly reported adverse side effect is the depression. However, this study does not mention that there is a very strong correlation with the same. And also the GLP-1 receptor agonist and related mental health issues, there was one study through the use of social media platform using the mixed method approach. It also tried to establish the impact of GLP-1 in with respect to emergence of the psychiatric side effect. However, establishing a clear cause and effect link between the metabolic disorders, depression, and medication is difficult because of their underlying reciprocal relation with the etiology, mechanism, and also the individual differences. The role of GLP agonist in terms of addiction has also been reported, like it works in the reward pathway, the hedonic pathway. That it has been mentioned that semaglutide, liraglutide causes to just impair the reward pathway. So it is said that it could be useful in the addictive disorders. Like it has been reported that it helps in addiction like alcohol, tobacco, cocaine, those who have a frequent habit of nail biting, and also those who have a compulsive shopping habit. So as to just gain reward, such behavior is repeated. But the precise mechanism about the GLP-1 receptor agonist action on addiction-related endpoints have not yet been clearly established, and there is no well-defined circuit-level mechanism that is identified. So what is the impact statement is that we have to be very cautious. Every healthcare professional should be aware of the potential psychiatric side effects before considering semaglutide, liraglutide, because we have to just be very cautious while assessing a patient. So we have to take the history, whether he or she has a previous history of psychiatric illness or not, whether he has a past history of self-harm, suicide, any family history of psychiatric illness. So the patients should be encouraged to report any change in their mood or behavior in subsequent follow-ups, and they have to be screened regularly. And the regulatory agencies should also play an important role in reviewing the safety profile of the GLP-1 receptor agonist, and careful consideration is required. So the neuropsychiatric safety is again an issue to consider, because we lack many of the conclusive randomized control trial studies. And so the management, let's come to the management of obesity and psychiatric disorder. The all psychiatric disorders and those who come up with obesity, we have to be very careful in deciding the medication, and this is dependent on the individual basis, because anti-obesity medication try to control the reward pathway. Those they decrease the hedonic eating pattern. However, it has certain contraindications. So naltrexone is available, that is anti-opiate. Bupropion is available, that is anti-dopaminergic, that is used as in case of weight reduction. But the pharmacological measures is not fully giving the good results, because ultimately what is important is we should also do this in a multidisciplinary approach. We should also be able to give them the non-pharmacological measures in terms of behavioral therapy. So let's understand what is the role of a psychiatrist. We should basically be there in the treatment of such individual who come with mental illness, who come with obesity. That routine screening is necessary, monitoring is necessary, targeting obesity in such populations is necessary, because they have a lot of psychological correlates that is underlying. And also the medication related weight gain issues. So behavioral management is play a key role here. Apart from that, most important is the stress management, and there should be the such type of measures should be in the contingency management, because consistency is a key, acceptance is a key, that they have the issues of obesity and so on. So providing a more consistent guidance for the patient, engaging all of us, like the endocrinologist, psychiatrist, psychologist, dietitian, play a very important role in managing them. And psychological evaluation play a very important role for those who undergo the bariatric surgery. The psychiatric clearance has to be given, because it helps to determine whether the individual is emotionally stable or not, whether he or she is ready for the surgery or not. And to just tell the people that the psychoeducational and support group is available, and then they can also come up for the counseling. And it helps in the overall effective management treatment approaches. So the take home message of the today's presentation is mental illness and obesity are the two separate chronic illnesses that require a long term follow up, long term treatment. Obesity and mental health both is considered as a fundamental and complex interaction to play both genetic, environmental, and multiple psychosocial factors. Obesity and mental health both poses an important public health concern. Decision to start the drug therapy for obesity should be made by case to case basis, individual to individual, understanding their own preferences and weighing the risk and benefit. And it is very important so to set the clear treatment goals and to consider the treatment preferences as per the tolerability, because it is has an impact to the adherence and compliance to the drug and the treatment approach. So the multidisciplinary collaboration is necessary to provide the effective management. Thank you so much for patience listening.
थैंक यू डॉक्टर बबीता, थैंक यू सो मच, वंडरफुल टॉक। एंड आपने इतनी आसानी से आपने सारा ये दो डिजीजेस इतनी बड़ी वाली मेंटल हेल्थ एंड ओबेसिटी को इकट्ठा कर दिया। देयर आर सो मेनी कमेंट्स एंड क्वेश्चंस कमिंग फॉर यू। विनायक शर्मा जी भी आपको गुड इवनिंग कर रहे हैं, एंड रमनदीप कौर सेज थैंक यू सो मच मैम, आई हैव लर्नड मोर अबाउट मेडिसिन, आल्सो अबाउट इंग्लिश फ्रॉम यू, योर डिक्शन इज फ्लॉलेस। रेखा बिठारा मैडम है, हु इज अ सीनियर एडवोकेट फॉर हेल्थ एजुकेशन, वो भी गुड इवनिंग कर रही है, एंड एक अली नजाकत साहब से गुड इवनिंग आ रहा है। एंड देन वन ऑफ आवर यंगेस्ट पीडियाट्रिशियंस, सर इज 73 इयर्स यंग, डॉक्टर रमेश पाल सिंह पवार सर फ्रॉम वेस्टर्न यूपी, वो आपको नमस्ते कर रहे हैं। There is one question. You mentioned that obesity can lead to psychological disease, and psychological disease also sometimes it can cause obesity because of comfort eating. We tend to eat too much, we dysregulate our eating. So in general, what comes first? So the question is, obesity pandemic hai in Nepal, in India, everywhere there are so many people who are obese. So what is it that comes first? First, is it a biochemical dysregulation, endocrine dysregulation, or is it a psychological or eating dysregulation? What comes first?
So this is a very important question you have raised, because it has a bi-directional relationship, and it is very difficult to give conclusive thing that what comes first, egg come first or the hen. So it has a very important thing. We have to understand that it comes up with a multiple causation. Genetics plays an important role. Environmental factors play an important role. The psychosocial concern play a very important role. So it is related to both of this, so there is a close connection.
Thank you. One question I will take, this is from Dr. Mukesh Makrolia. He asks, how do I differentiate hypothyroidism due to obesity or obesity due to hypothyroid? So Dr. Mukesh, again, very important question. General rules are, if TSH is more than 10, we begin treating. If TSH is any number and T3, T4 are low, again we begin treating. That is clinical or overt hypothyroid. Suppose TSH is 5.5 and you have an obese boy or obese lady, then there is a challenge. So you can take a family history. If there is a strong family of autoimmune disease or hypothyroidism, we begin treating. You can also ask for personal history. Any history of exposure to radiation, surgery, chemotherapy, surgery of the neck, then also we will begin treating. If we are not sure, we can do antibodies. If anti-TG and anti-TPO are highly positive, that means patient has got autoimmune disease, so we will treat the patient. But मान लो हम ये टेस्ट नहीं करा पाए या पेशेंट के पास पैसे नहीं है, there's no harm in doing a 45-day trial. Therapeutic trial is, we tell the patient, so this is how we speak, हो सकता है आपका थायराइड वेट की वजह से हो सकता है वेट की वजह से हाइपोथायराइड हो, the same thing you are saying. So let us try to lose weight. If we lose weight by let us say 5%, maybe our TSH will come down. And this is actually true, because what you see is that there is a direct relationship between TSH levels and body mass index. If we are able to bring the body mass index down by 1 or 2 points, the TSH will also come down by 1 or 2 points. So you do a therapeutic trial for 45 days and see what happens. This is quite rewarding in practice, क्योंकि फिर हम पेशेंट को भी लगता है कि डॉक्टर लगे हुए हैं, so our tone in the OPD is, चलो इकट्ठे काम करते हैं, let's work together to fight this thyroid, देखते हैं कि जड़ से निकलता है कि नहीं. So these are some ways of handling. ये हम कब नहीं करेंगे? When we will not do this, if it is a young lady who is planning pregnancy or who is actually antenatal, then it is not a good idea to wait. Then we should try to bring the TSH down to below 2.5, so you begin the treatment. So I hope that helps. And Dr. Babita, there's one more question, and that is that so many new drugs are coming, semaglutide, liraglutide. Uh, these drugs act upon the gut. They also act upon the pancreas and upon the brain. Do you think that we are going to create a new epidemic of drug dependence? तो पहले substance abuse होता था different type का, like you have substance abuse for alcohol, tobacco, and now we are going to have drug dependence on newer GLP-1 RA. Do you think that we might be heading towards that?
So at with available current literature, so it is, I think it is very difficult to go to that conclusive thing, because the semaglutide, liraglutide, what they have been seen that uh, it helps in the addiction, like it helps in form of like reducing the craving for alcohol, tobacco, and some of the evidence are there for the cocaine also, nail biting also, and those who have the compulsive shopping habit also. But the thing is, practically in my clinical experience, I don't have experience of using this drug, as it comes with a lot of like there are upcoming emerging evidence that it is associated with the neuropsychiatric adverse effect. So I feel we should wait for more uh, conclusive, more evidence based clinical trials.
Uh, Point well taken. And in practice, when we use them, we actually see that many patients, not all, but many patients do come back and tell us that their craving for alcohol, especially, and slightly for tobacco, has gone down. So maybe the same, like you spoke about hedonistic eating, the same factors in the hypothalamus make us hungry for tasty food, and the same factors make us hungry for or thirsty for
Yes,
alcohol or tobacco.
the reward pathway. Yes.
The reward pathway. So actually, instead of drug dependence, we hopefully we will look forward to a future where these drugs prevent drug dependence or they prevent substance abuse. There is also, ma'am, when we speak of psychology, psychiatry, and neurology, it is one spectrum. So there is also data that these newer drugs like semaglutide, for example, are being used in Alzheimer's disease and dementia, and studies are also ongoing. So from a psychiatry perspective, would you like to talk about dementia? How does it impact psychological health, psychiatric health, and what kind of things should we be careful of when we are handling people with maybe with reduced cognitive function and also with diabetes? Like for example, the family comes to you and say कि ये जो मरीज हैं इनको साइकेट्रिक डिसऑर्डर है, ये भूल जाते हैं, उल्टा पुल्टा बोलते हैं, तो हाउ डू एज लेमैन हाउ डू वी फिगर आउट कि इनको साइकेट्रिक इलनेस है या न्यूरोलॉजिक इलनेस है? What are the pointers in history?
Sir, okay. So to understand that, we have to first rule out, like there is a term called pseudo dementia and a clear dementia. So pseudo dementia occurs because of nutritional deficiency, B12 deficiency, because of hypothyroidism, and also because of depression. So we have to understand whether there is a temporary reversal of the illness or the permanent, the cognitive disturbances that goes on. And the dementia, it come up with multiple behavioral and psychological issues, and the problem keep on continuing, like there is increasing consequences because of that. And we have to make them understand there is a very important role of a caregiver, because it is very important for them to understand the disease itself and how to approach those individuals. And there is a clear treatment for, yes, there is a reverse, because if we provide the supplement, if we provide the antidepressant, then the depression goes away, the pseudo dementia goes away. But however, in terms of dementia, that we have certain neuromodulating drugs, like we have certain drugs, but it is not going to reverse back the illness. So that is the thing I would like to convey.
That is really important and helpful for us. So एनी टाइम अ पर्सन कम्स टू यू, आप सोसाइटी में देखते हैं, फैमिली में देखते हैं, आपको लगता है, दो दीज आर रॉन्ग वर्ड्स टू यूज, कि मरीज पागल हो गए हैं, पागलपन की तरफ जा रहे हैं, भुलक्कड़ हो गए हैं. इट्स नॉट दैट एवरीबडी हैज गॉट डिमेंशिया, एंड इट इज ऑल्सो नॉट दैट एवरीबडी हैज गॉट सूडो डिमेंशिया. तो एक बार एक डॉक्टर के पास जरूर ले जाएं. एंड जो साइकाइट्रिस्ट हैं वो तुरंत बात करके कुछ ही मिनट में वो पहचान जाएंगे कि ये साइकाइट्रिक इलनेस है या हमें और कोई टेस्ट कराने हैं, कोई सीटी स्कैन या एमआरआई कराना है. And your psychiatrist or neurologist will also be able to tell you how much improvement we can bring in the symptoms. One more cause, ma'am, like Dr. Mukesh said, another cause of pseudo dementia is hypothyroidism. Many times that is missed. So you feel that the lady is elderly, she is forgetting things, and everybody will say, "ये तो सठिया गई हैं," in Hindi. She has gone into senile dementia. Actually, she has got high TSH. And another common cause which we miss many times, especially in summer, that is hyponatremia, low sodium. तो नमक की कमी और थायराइड टीएसएच का ज्यादा होना, ये भी कॉमन रीजंस हैं इन चीजों के, तो वी शुड रूल देम आउट. डायबिटीज डिमेंशिया एक भी टर्म है. सो मैम, इन योर ओपीडी प्रैक्टिस, लाइक यू हैव गॉट नाउ 1 decade एक्सपीरियंस, द नंबर ऑफ पीपल विद डायबिटीज एंड द नंबर ऑफ पीपल विद ओबेसिटी in your clinic, is that going up?
Yes, sir. Even in my residency, I used to see many of the patients who come with dementia, sorry, with depression as well as diabetes, because there is also a strong link between, because there is a cause, like those who are elderly, most of them who have a diabetes, so they have a history of depression, and we have to rule out it is because of the diabetes itself or it is independent. So that is, there is how the history plays a very important role, and management is decided there by whether there is a good glycemic control or not. So this is how we have to look.
And again, this is important for the general public. सब लोग हमारे हेल्थ एडवोकेट्स हैं लॉक्ड इन. कभी कभी लो शुगर से, हाइपोग्लाइसीमिया से, लो ग्लूकोज से भी भुलक्कड़पन या गलती होती है. सो इफ यू आर एबल टू, पेशेंट कम्स एंड सेज, या आपके कलीग या फैमिली मेंबर बोलते हैं कि रोज दोपहर को 1, 1:30, 2 बजे पता नहीं मुझे क्या हो जाता है, ऐसे लगता है जैसे नशा चढ़ गया है, गलतियां करनी शुरू कर देती हूँ मैं, गलतियां करनी शुरू करता हूँ. इट इज पॉसिबल के हाइपोग्लाइसीमिया हो. या बाकी टाइम पेशेंट बिल्कुल ठीक है, सुबह उठते हैं ऐसे लगता है जैसे नशा चढ़ा रखा है. सो पेशेंट विल कम एंड से, सर आई स्वेयर आई हैव नेवर इवन स्मेल्ड अल्कोहल इन माय लाइफ, बट दीज डेज एवरी टाइम आई वेक अप इन द मॉर्निंग, मुझे ऐसे फीलिंग आती है जैसे रात को किसी ने मुझे अल्कोहल पिला दिया हो. नाश्ता करके मैं ठीक हो जाता हूँ, आफ्टर टेकिंग ब्रेकफास्ट आई एम फाइन. सो दिस इज ऑल्सो अ साइन ऑफ हाइपोग्लाइसीमिया. Once, Dr. Babita, we had a priest, a Pandit ji the, whose complaint was that when I sit down for prayer early morning, khali pet, I am very fine. But the moment I try to reach Anand, bliss, so I am praying to God. The moment I try to become one with God, suddenly मेरे दिमाग में शिव जी आ जाते हैं, and he starts doing a तांडव नृत्य. He starts dancing in my head. And actually, what was happening, the patient was taking sulfonylurea in the morning, sitting down to pray, and after 2 or 3 hours, he would go into hypoglycemia. So he was getting those kind of feelings. And because he was a very religious person, he used to think that God is punishing me. I must have done something wrong. That is why Shivji is coming and punishing me. But actually, what was happening was that he was taking the wrong medicine. So we changed the anti-diabetic drug, and we told him कि आप 4 घंटे प्रेयर करना चाहें करें, पर 1-2 घंटे के बाद आप जो सज्जन बैठे हैं उनको भी आप प्रसाद खिला दें और खुद भी प्रसाद खा लें during the prayer, and then he achieved that feeling of anand or bliss. So these are also things where actually the cause is biological, but you may feel that it is a psychological or psychiatric or neurological cause. तो वो हिस्ट्री टेकिंग से ठीक हो जाता है. It's been great being with you, ma'am. हमारे साथ बतूल है backstage. Batul takes care of us. So Batul, what have you learned today from Dr. Babita Sharma, madam?
थैंक यू सो मच. अ लॉट ऑफ थिंग्स एक्चुअली किस तरीके से ओबेसिटी इंपॉर्टेंट रोल प्ले करता है हमारे मेंटल हेल्थ में. बहुत ज़्यादा नेग्लेक्टेड पार्ट है, बहुत ज़्यादा इस पर फोकस नहीं किया जाता है, एंड वी वर नॉट इवन अवेयर कि किस तरीके से एक पर्टिकुलर वेट गेन एक पर्टिकुलर टाइम पीरियड के बाद अगर होता है तो वो हमारे मेंटल हेल्थ से कैसे एसोसिएट हो सकता है और हमारी डेली लाइफ को किस तरीके से इम्पैक्ट करता है. सो थैंक यू सो मच मैम फॉर मेकिंग अस अवेयर ऑफ इट, एंड आई एम प्रीटी श्योर कि इसके बाद जो अवेयरनेस हमारे प्लेटफॉर्म के थ्रू हमारे व्यूअर्स तक पहुंचा होगा, जिससे हमें ये पता रहेगा कि हमें अगर हम ओबेस हो रहे हैं तो उससे हमें किस तरीके से डील करना चाहिए और हमारे मेंटल हेल्थ को ध्यान में रखते हुए हमारे लाइफस्टाइल पे किस तरीके से फोकस करना चाहिए. सो थैंक यू सो मच मैम, थैंक यू फॉर दैट.
Thank
मैं
you.
भी मैडम को, बतूल को थैंक यू. वुड यू शो अ सर्टिफिकेट ऑफ एप्रिसिएशन फॉर डॉक्टर बबीता?
Thank you.
थैंक यू सो
Thank you
मच
so
मैडम.
much.
मैं भी मैडम को थैंक यू करना चाहूंगा फॉर हैविंग जॉइंड अस. मैडम इज वन ऑफ द लीडर्स इन द अपकमिंग फील्ड ऑफ पैरोसाइकाइट्री, जिसमें वेट गेन और साइकाइट्री का जो कॉम्बिनेशन है उसको देखते हैं. अनदर टर्म फॉर दिस इज मेटाबॉलिक साइकाइट्री, जिसमें बाकी चीजें भी आ जाती हैं, जैसे शुगर, थायराइड, सोडियम, ये चीजें भी आ जाती हैं. And we look forward, madam, to your continued leadership and advocacy, not only in Nepal, not only in India, but across South Asia and the world at large. Before we conclude, any take-home message for the entire audience that is listening to us?
The main take-home message is that there is a interlink between obesity and mental illness, and we should be very cautious, and we should practice physical activity, behavioral strategies also, and very important, the main root cause, the stress management, play a very important role in both mental illness and also in obesity. And we should learn the very good healthy coping mechanism and avoid the maladaptive pattern of behavior. So I think that is going to help us and keep us healthy.
So ongoing work for us, ये तो पूरी लाइफ भर चलता रहेगा, stress management and proper coping. So madam, we'll invite you again to learn more from you. तब तक शुक्रिया, धन्यवाद, मेहरबानी. एंड हरियाणवी में जैसे हम बोलते हैं, थारा बलाओ. सबको जय हिंद और जय नेपाल.
Thank you. Namaste.